All right, guys. Okay. It's Sunday night service with Dani, and Dr. Motley is not here tonight. He is on an airplane coming home from Texas, Dallas, Texas tonight. But I am so thrilled to have Dr. Dennis Goodman here with us from New York City. And you can see in the background there, he's got New York City in the background. World famous, renowned cardiologist, and now functional medicine integrative cardiologist. Dr. Goodman, thank you so much for being here tonight.
Thank you so much. Do I call you Dani or?
Call me Dani. That's who I am. Yes, yes. So
I'm excited about it, and I've never done a show in Tennessee.
You've never done it, no, and clearly you're not from Tennessee or New York City. No. Go ahead. Sorry.
Competing with the Oscars, you know that?
I know we are. For the last 3 weeks, we have competed with the Olympics, so it's been tough. I'm ready to get this over with, so it's all about us again. But every Sunday night, Dr. Goodman, we do a live show called Sunday Night Service, and we feature different topics. We've done everything from methylation to detox to sex drive. We did a part 1 and part 2 on sex, to nutrient deficiencies, cold and flu virus. We've done it all. And so tonight, guys, I'm thrilled to death. I'm a week late as usual for Heart Month, American Heart Month. Yeah. So anyway, I'm wearing red for heart health, but I'm going to start off tonight while people are logging on and we're getting people on. Guys, as you all log on, click your heart buttons, click your like buttons so that we know you're on there, because we are on a completely different program tonight other than Facebook Live. So I need to know if people are actually watching or if you can hear us tonight. So this a little, there we go. I see. Hey, Dani. Oh, Lisa's on. Hey, Dani and Dr. Goodman. Okay. I'm going to start off with some statistics. Then I'm going to tell you a little bit about this man we have in front of us here. These statistics come from his book, as well as from the American Cardiology Association. Is that correct? American Cardiology Association?
American Heart Association.
The American Heart. Well, actually, I think, okay, yes.
And the American College of Cardiology.
That's it, the College of Cardiology. I got some of these off of there. All right, guys. By the year 2035, do you know that greater than 130 million adults in the United States are projected to have some form of cardiovascular disease? And the total cost of cardiovascular disease are expected to reach $1.1 trillion by 2035. That came off of your cardiology page. More than 2,150 Americans die of heart disease each day. That's an average of 1 death every 39 seconds. So we've been on 4 minutes. That means what? 6 people have died in the 4 minutes we've been on. An average of 150,000 Americans who die of heart disease each year are younger than 65 years old. All right, 33% of all deaths caused by heart disease occur before the age of 75, well below the average life expectancy of 77.9. That's horrifying to me. Coronary heart disease causes 1 in every 6 deaths in the United States, while 1 in 18 deaths are caused by stroke. Unbelievable. An average of 800,000 Americans die a year of heart disease. 800,000? That's unbelievable. Approximately 750,000 Americans have a heart attack, have a heart attack, and 470,000 more have a repeat heart attack. Approximately 195,000 Americans experience their first silent heart attack each year. Now that's scary, undiagnosed or unnoticed, right? 195,000 approximately. That's right. That's unbelievable. Approximately, 25 seconds. Every 25 seconds, an American will have a coronary event, and approximately every 1 minute, someone will die of one. That's crazy. Median survival of those greater than 45 years after their first heart attack is 8.4 years for white males, 5.6 years for white females, 7 years for black males, and 5.5 years for black females. That's terrible, right? Sudden cardiac death appears to be appears among the multiple causes of death on 13.5% of death certificates. And that suggests that 1 of every 7.4 people in the United States will die of a sudden cardiac death. Wow. All right. Death is the first and last symptom for half of the people who die of a heart attack. Sudden cardiac death is your first symptom and your last symptom for half of all people who die of a cardiovascular event. Isn't that unbelievable? Yeah, which exactly is the reason you need to be seeing your primary care provider, your cardiologist, right? Your integrative healthcare nurse practitioner, what have you, to get your heart health on track. So tonight we're going to talk about preventable risks, preventable, unpreventable, the magnificent mineral of magnesium that you write so beautifully about, and as well as many other things that you want to talk about. So we've got a lot of people logged on tonight. Now, I don't know, Dr. Goodman, can you see the, are you able to see the comments?
I can see. I can see.
Can?
Yeah. Are people able to ask questions? Do they?
Yes, they're asking they can ask questions. They're talking about those statistics are just mind-boggling. They're, just on and on. They're talking. So you guys, as you log on, click your like button and all. All right, I'm going to tell you about, we've got people logged on now. So we're going to get started. Dr. Dennis Goodman. He graduated cum laude, you smarty pants, with distinction from the University of Cape Town, right? Medical school in Cape Town, South Africa. I won't tell what year. No, I don't think I was born yet. No, I was. All right. He did his internship in Cape Town, South Africa as well. And he did it where the first heart transplant was performed in 1969. I didn't know that. I didn't know the first heart transplant was performed in South Africa. He completed his internal medicine residency and was the chief medical resident in Pittsburgh, Pennsylvania. His cardiology fellowship was at Baylor University. That's where Allie, my office manager, and her husband went to school. Fantastic school. He's a board certified in internal medicine, cardiology, interventional cardiology, critical care, clinical lipidology, cardiac CT, and holistic integrative medicine. In 1988, Dr. Goodman joined the Scripps Memorial Hospital in La Jolla, California. That's where in 2000, he was elected chief of cardiology and medical director of the cardiac rehab program there. And then he spent 2 years when he decided to step out of the boat in the integrative medicine training there, right? Yeah, he is a national and an internationally known speaker, educator, teacher. He spoke at our Integrative Healthcare Symposium last week in New York City, which is how I met him. He's been a visiting medical professor in South Africa, Asia, Israel, and Europe. He's published many articles, and he's formulated I didn't know this, a natural cardiovascular supplement to help treat cholesterol problems. We might have to talk about that tonight. He's appeared on all kinds of TV shows, radio shows. He also is a talk show host for Dr. Radio. I didn't know that, on Sirius XM 119. And he is consistently named one of New York's and the United States top doctors.
Are we going to waste half the show talking?
Yeah, I just keep going. This is crazy. This is long. He's board certified in about everything you can be board certified in. All right. And he's the author. This is very important. The author, we already know he's a smart man. He's the author of Magnificent Magnesium, The Thrill of Krill, as well as Vitamin K2, the missing nutrient for cardiac and bone disease. And I have really been all over K2 lately, so I can't wait to learn from you about K2. He's currently, though, right now, a clinical professor of medicine and on the faculty of the Leon H. Cheney Division of Cardiology and Preventive Medicine at New York University in New York City. He's the director of integrative medicine and the wellness program at NYU. And I am thrilled and honored that you're here tonight.
Thank you, Dani.
Thank you. That is huge. That's a big bio.
No, I don't know if we've got anybody left. Are there anybody still listening?
Oh, they're still here. You guys are still here. Yeah, they are. All right. So thank you for being here. And I am honored and thrilled to have you. I'm missing Dr. Motley tonight, but thank you for taking time out of your night. Talk to us.
You know what? I want to commend you. because what you're doing is taking a lot of time, not only of one night, of every week, and what you do on a daily basis is to really educate people. And you mentioned these really horrifying statistics. And if we can actually just get one person who's listening tonight to go and be checked and find out that they may have some problem that they need to, address, we can save a life just by what we're doing here for half an hour, 45 minutes.
Isn't that something? Yeah, I love what I do. And I saw firsthand with your presentation in New York that you love what you do. And I'm telling you, people, this man has a heart. He has a real heart for what he does. And it's a good thing you're a heart doctor, right? I mean, he really does. He's humble, he's kind, and he has the patient's heart, right, with it at his best interest. Tell me, how did you step out of the boat? What made you decide to transition from a traditional cardiologist to an integrative medicine cardiologist?
That's a great question. And I've always felt that I'm interested, and I've been interested beyond just traditional medicine. And in fact, as you mentioned, I was an interventional cardiologist. I trained at Baylor College of Medicine. And so I was, busy running to the emergency rooms when people had heart attacks, and we took them urgently to the cath lab, and we did angiograms and cardiac catheterizations, and I would open up the artery, and I would, sometimes I'd put a stent in, and I started to realize that I felt like a fireman.
Right.
Putting out a fire, and this house is burning down, and this person is in, deep trouble. And then sometimes, and obviously that's what you'd hope for, that we'd have a great result, and you really kind of felt, wow, I made a huge difference. And sometimes it made no difference, and the house burnt down. And I started to think about the fact that I want to spend my energy and my time helping people to prevent heart attacks.
Right.
And if they've had a heart attack or stroke, to prevent them having another one. So to go back to like something you said, which is so scary, that 50% of people who die of a heart attack, it's their first and last symptom. And you sort of alluded to this. It's a scary thought that you can be fine one day and you actually sitting on a time bomb. And this is what's so important, that people are aware of whether or not they're at high risk. And
right.
We have the technology today to be able to tell people if they are at high risk. It's not like we have to guess. We actually have enough information from simple non-invasive tests that we can really tell people. Let me go back to one of your other points. It turns out that 1 in 2 men die of cardiovascular disease.
1 in 2.
1 in 2. So you mentioned all these statistics, but cardiovascular disease is going to include, heart attack, stroke, an aneurysm that ruptures, something like that. So it's very, very common. And for women, it's something like 1 in 3. So Dan, make this very important point to the women that are listening tonight. Women are very focused. They do understand that there is a risk of breast cancer, right? And they will go and have yearly mammograms there, and they don't question it. Turns out that 1 in 8 women, will actually get breast cancer, which is a lot. But only 1 in 32, it sounds like only, will die of breast cancer, whereas 1 in 3 will die of heart disease. So what I'm saying is women will, because they've been educated and they understand that I want to find out, I want to be checked every year, they have mammograms, but it's much more common to have heart disease and to die of heart disease. So I'm making the plug, and you're wearing that red dress tonight because we just had a month where we were very focused on women and men. It was Heart Disease Month. So my plea tonight is that people understand whether or not you have increased risk and whether or not you're sitting on a time bomb. So I sort of went around from your question. And so what I did is I went to the Scripps Integrative Medicine program under Mimi Guarneri, and I went there for nearly 2 years. And I learned and I got a feel for integrative medicine, which is really holistic and complementary medicine, not alternative medicine. This is in combination with what traditional medicine offers. This is not a competition. We're not trying to do something alternative. We're trying to say, what is the best thing that we can do for people?
Right.
And I am a big believer the best thing we can do is get people to be motivated to take care of themselves.
Amen to that. I knew I liked you from the minute I met you.
80% of heart attacks and strokes are preventable.
80%.
with lifestyle changes and taking care of yourself. Now, most people don't. And that's why we have these terrible statistics that you ran through. So I have now very much focused on preventative and integrative medicine, helping people understand that they can make a huge difference to their risk just by taking on board the most important things, which are nutrition, exercise and flexibility, sleeping well, being screened for sleep apnea, and stress management. So that's the focus of what I'm doing now. And I have really enjoyed moving from being a fireman trying to put out the fire to trying to make a much greater impact and actually affecting hopefully thousands and tens of thousands of people, because just like tonight, we're going to have some people that after the show will say, I do want to visit my doctor or my nurse practitioner or my healthcare provider, and I want to go through what are the things that are going to put me at risk. Do I have increased risk?
Right.
And I think we should at least discuss that, because
let's talk about that.
If you have increased risk. So just to come back to something you once asked me, like, well, what is cardiovascular disease and coronary artery disease?
Yes. I think people confuse that. And I think doctors sometimes mix it up too, or use it interchangeably.
That's right. So when you think of the word cardiovascular, we're talking about the heart, and vascular means the blood vessels. So anything to do with the heart or the blood vessels that supply your whole body, that is cardiovascular disease. So it could be a blockage in your carotid artery. I'm pointing to it here. So that would be atherosclerotic cerebrovascular disease, but it would fall under the category, of cardiovascular disease because it is in your vessels.
Okay.
So we have to. So when you talk about coronary artery disease, which is now we're talking about the blood vessels that supply blood to the heart, that is just under the umbrella of cardiovascular disease. Okay,
I get it.
So if you've got a carotid stenosis or disease there, that's also under the umbrella. But that would be a blockage in the carotid. You may have a blockage down in your legs. We call that, peripheral arterial disease.
Right.
You may have an aneurysm in your stomach or in your belly or in your thorax. It's also part of cardiovascular disease, but it's under peripheral vascular disease because it's not affecting the heart. It's outside of the heart. So that's the story with cardiovascular disease. Now, what are the things that you should be thinking about? What are the classic risk factors for cardiovascular disease? So we know, right, Dani? What are some of them? I'm going to be quizzing you tonight.
Well, some of the classic ones are age, right? Genetics.
So let's go slowly. The older
age,
absolutely. That's 100.
The older you get,
and especially what we should tell women, their risk goes up significantly after menopause.
And see, that's what I'm in the middle of right now. So just in the middle. Yes. And so why does it go up after menopause?
Good question.
I believe I know, but you tell us, since you're the cardiologist.
You can tell them.
You tell us. You tell us. They hear me talk all the time.
And the reason is prior to menopause, you have enough estrogen, and estrogen is protective. But once you get to menopause and your ovaries aren't working and functioning properly, you get into a situation of a low estrogenic state, and you lose the protection. And that's why what actually happens, cardiovascular disease increases significantly, and women end up catching up to men.
Wow.
So initially, they are behind, 10 years behind. So like a 59-year-old man would be like a 49-year-old male. But after menopause, it increases so quickly and escalates that they catch up. And that's why you still have this high incidence of women, 1 in 3 of dying of heart disease, of cardiovascular.
Really? Oh, okay.
So very important that you're aware that as you get older, the risk goes up. You mentioned another important one, family history.
Okay.
So we think of family history as being significant if you have a mother who has an event below age 65.
A mother. Okay.
That's your mother. That means like a heart attack or a stroke or something cardiovascular, less than 65 would be a significant family history.
Okay.
Or a father less than 55.
Okay. Mother less than 65, father less than 55. Got it.
So those are the major, those are the ones that we go, okay, significant risk factor. But if you've got grandparents who've got who've got the same thing, or you've got brothers and sisters with the same thing, that also increases the risk, obviously. But the biggest risk in terms of family history is a mother or father.
Okay. All right. But you don't have to be your genetics either, right?
No, and remember that, and we've got to tell people this. You know, the genetics, and I hate to talk about guns, but I mean, we talk about a loaded gun when you've got the genetics.
Yes.
Pulling the trigger is something that you can be in control of. And you can have a genetic predisposition, but it's what you do. The environmental factors and what you do to yourself and what you don't do. You just don't take care of yourself. That's when the trigger gets pulled.
You bet.
That is called epigenetics.
Yep, it sure is. On top of your genes, yes.
A bad family history, there's nothing I can do about it, is really not good thinking. It's not how we think today. We think you can control your genetics with medication.
That's right.
So that's two of them. So what would be, let's go to a few more. So what would be another very significant risk factor for cardiovascular disease?
Smoking.
Absolutely. So people. And there's still a lot of people smoking, and that's
I have that statistic somewhere. How many people are still smoking? It doesn't matter. But it's estimated that 7.2 million deaths worldwide in 2015 were attributed to smoking. Right. Isn't that something? Okay, so tell me about smoking.
There's still a lot of youngsters stop picking up cigarettes and starting to smoke. Yeah, and I actually just I was reading the New York Times this morning, and there was a court that ruled that one of the cigarette companies had to advertise that secondhand smoking causes significant problems. And it turns out that there are many deaths from people being exposed to smoking from someone else, and it affects children, and it affects them. Understand that if you're with someone who's smoking, even that puts you at increased risk.
Yes, it does. It certainly does.
Okay, so cigarettes, let's get to high blood pressure. So we can talk about hypertension, high cholesterol, high LDL cholesterol is a significant risk factor, as well as high triglycerides and low HDL cholesterol. Diabetes is more than just a risk factor. We consider people with diabetes as we treat them as if they've got cardiovascular disease. So that's a significant risk factor. And then obesity and sedentary lifestyle. So, and then stress. So I wanted to run through them so that if anybody wants to jump on that, we've just gone through the major risk factors for cardiovascular.
Yes, sir.
Now, can you do something about most of them? Absolutely. There are only 2 of those that are non-modifiable. Actually, the rest of them you can.
Your genetics.
Your genetics is non-modifiable, and what else?
Your age.
Yes.
Oh, I don't know. Really? Okay. You can't change that.
And maybe, your gender and your genetics, but the rest of them, which is most of them, you can modify with lifestyle change.
Yes, you can. By eating well, sleeping well, moving well, pooping well, decreasing stress, and having community.
I love that picture on your Facebook page.
Thank you.
That actually says it all.
Thank you. Okay.
So we want to just empower people to go and be checked. Have your blood pressure taken. You should know what your cholesterol is. You should make sure that you know what your blood sugar is and that you don't have diabetes. And get a doctor to say to you, we have a way now that you can actually see what your cardiovascular risk is. I mentioned this in my talk in New York, and that's called the Asc Vd Calculator.
Yes.
And you should tell everybody about that because it's an app.
I shared that at the Hashimoto's meeting Friday night, actually, with them.
So you can actually go onto apps, and you can get this app called Asc Vd, and you actually have the app, and then you put in these things we spoke about. How old are you? What gender are you? What's your blood pressure? What's your cholesterol? And it tells you what your cardiovascular risk is over the next 10 years.
Yes.
Anything above 7.5% is significant.
Anything above 7.5%?
7.5% would be
cut out on me.
A significant risk.
Okay.
And that's a group that, we can talk about this another day, but that's a group that the American Heart Association, American Cardiology feel that people should be on statins. So that's another topic. We're not going to go there tonight.
Yeah, that'll start a storm over here on this page. Okay.
Right. So that's the cardiovascular risk factors.
Yes,
now,
sir.
If you go to a doctor and they land up saying, are you having any symptoms? And you say, well, I got a funny bit of chest pain, this and that. And they want to decide whether or not your chest pain is coming from your heart. Okay. Then they usually do something called a stress test. Do you do those, Dani, or do you send them off to a cardiologist? What do you do?
I send them to a cardiologist because I don't do primary care anymore, so I don't order that. The only thing I do order is a cardiac calcium score test. But I get them off to a cardiologist.
I want to make the point that if you have a stress test and you walk on the treadmill, or you do a stress echo or an exercise nuclear stress test, we are screening for a blockage above 70%.
Okay.
You're not going to detect blockages below that on a stress test. So a person can pass a stress test and still be sitting with significant cardiovascular disease.
Really?
Very important to understand. Just because you pass the stress test does not mean that you are free of disease.
Oh, no. Okay, I passed mine with flying colors. Okay.
Now, all it tells you is you do not have a blockage of 70% or more.
Oh, good Lord. I didn't know that. Okay.
So that means, how do we tell if someone's sitting with plaques or blockages of less than 70%? And you just mentioned the test that you like to get, which I use a lot of, and that's called a calcium scan.
Do you like that scan?
I use it a lot. I really like it.
Okay, so I use it a lot as well. It's very inexpensive here in Nashville. It's like $62 to have it.
We can get them here in New York for like $95.
Okay, so it's a little bit less here. I had a score of 0.
That's good.
Okay, so mine was good. And then I had a cardiologist. I had a patient who had it done, and then for some reason had it redone the next year. And it was up. The score was up. And I called the cardiologist here that I use, and he said he should not redo that test. You shouldn't redo it. Is that true? Should you ever redo a cardiac?
We believe you should do it one time.
One time. So you don't redo it in 5 years or 10 years.
Well, so let me say a caveat there. If someone's got multiple risk factors, and I'm trying to decide how aggressive to be. Okay. They are 45 years old or they're 50 years old. I may say to them, look, you're at an age group now where it could shift in 5 years. So in that subset, I may do it 5 years later. Okay. It could be 0 at 50, and then at 55, suddenly there's a lot of plaque. And I told you why, especially women, because they lose their estrogenic protective effect. Correct. So you can get a suddenly increase, and we do want to know. So what is so important for people to realize that a calcium scan can actually tell you whether you've got cardiovascular disease, because it looks for plaques in the coronary arteries. This is not where we, just let's be clear, you pointed to the carotid. Yeah, to the carotid. So it's down. So I went through the tube. Exactly. It's a CT scan. Yes. Which looks at calcifications in the coronary arteries. But we do another test in the carotids to get the same kind of information, and that's called a carotid ultrasound. A carotid ultrasound. Yep, I've ordered. Okay. Yes. So those are the two tests where we can look for what's going on in the blood vessels before someone is symptomatic. So would you recommend someone do that preventatively, especially if they have a first-generation mother or father? So it depends on the age. I don't send someone who's 35 or 40 in general for these tests because they're likely to be negative. Well, let's go with 50, like my age, 52. So if you had multiple risk factors, and you got bad genetics, you came in, you said you do smoke, you got high blood pressure, I would do it, because even if you're not symptomatic, I would say, let's find out, Dani, whether you're sitting on that, like I said, that ticking time bomb. Okay. Because what we want to do is detect people who have a lot of plaque, who have underlying coronary artery disease and carotid disease, so we can tell them, look, if you carry on doing what you're doing and we don't modify your risk, you're on track to have a heart attack. Right. So I do believe that it's a very helpful test, and it certainly helps me sometimes. As you mentioned, I do cardiology, I do lipidology. Sometimes I have to make a tough call about whether to put somebody on a statin for primary prevention. Now, it's not popular in your world, but there are people that are very high risk. They've got a bad family history, and they're sitting with a lot of plaque at age 40. Oh. And I believe that we should be aggressive in getting that person's LDL down significantly. So we could talk about this on another show, but there are people who need statins, both for clearly secondary prevention, which means they've already had an event, or in primary prevention when they're high risk. Right. Okay. So when you talk about getting a good history and physical, blood tests, and then doing these scans, we can tell somebody what their risk is. Okay. We can say, are you low, moderate, high risk, or minimal risk? You got a calcium score of 0, and you don't smoke, and your blood pressure is normal, and hopefully you don't have a bad family history. Your risk is minimal. we're talking less than 2%, somewhere around maybe 1%. Everybody's got some risk. But you can look up in the calculator, the Asc Vd Calculator, and you'll find out you've got a very low risk.
Yeah, I'm glad to know about that. You just mentioned labs. Do you check, what do you check specifically? Do you check a C-reactive protein and a homocysteine? I mean, I don't know. What do you check?
Are you talking just general labs? Or
I'm talking general labs.
So I get routine labs on people like you do, the blood counts, the
yes,
the SMAC, the thyroid function tests. And then I do a lipid panel, okay, which is just a general lipid, basic lipid panel. But if there's a question and they've got risk factors, I do something called advanced lipid testing, which advanced lipid testing tells you not just what your numbers are, but whether or not you have inflammatory markers. Because I use a lab called Boston Heart Lab. There's another one called Cleveland Heart Lab. We can tell now whether or not you've got a lot of inflammation in your body. So there are certain blood tests that tell us whether there's inflammation. One is HSCRP, but there's another one called PLA2. There's another one called myeloperoxidase. I mean, I'm just giving you these names, but just to mention to you, we can tell whether a person has inflammation, and predominantly in the vascular system, because it's the combination of inflammation plus high LDL cholesterol that puts at risk from atherosclerosis. It's the two together. That's why people who smoke, they are inflaming their arteries, and that's why they land up with such a lot of cardiovascular disease. So I do those labs, and I'll give you one example of how this advanced lipid testing helps me. Say a person's got an LDL of 160, which is fairly high, right? And they got a total cholesterol of 250. And they have an HDL that is high, which is often that's the good cholesterol. And the question is, are they at cardiovascular risk from that high LDL cholesterol, right? Because it's the bad cholesterol. This test looks at the LDL itself and says, is this more likely to be an atherogenic LDL particle or not? What does that mean? And I'm going to put it in very simple terms for you. The small, dense LDL particles are more dangerous. Okay, so I'll give you an analogy with tennis. If you're talking about tennis and you play tennis with tennis balls, which is what you use for tennis, and you hit the ball against the net, they do not go through. Okay? Because they touch it and the holes in the net. But what if you were playing with marbles or golf balls?
Right, it would go through.
So we can tell how many marbles and golf balls you have. And the more marbles and golf balls you have, the more you have these small, dense LDL particles, the greater the risk. So that's the kind of thing we can get on a Boston from an advanced lipid testing.
Does a Boston Heart do that?
Yeah.
Okay. I wonder if that new Cleveland Heart will, because Quest, and that's what we use in my office.
So that's your other option.
Connected with Cleveland, and I wonder if that's. I will find that out for you all that are watching.
And that I'm telling you, they do that. They do. They do because I use both of these tests.
You do. Okay.
Let's just say you're not trying to do an advanced lipid test. You should at least have the basic lipid panel, which is called a fasting lipid panel, which is going to give your cholesterol, your LDL cholesterol, the HDL cholesterol, the triglycerides, and the cholesterol to HDL ratio. And so we should have that information, because if you're sitting with a very high LDL cholesterol, that is a risk factor. Or you're sitting with high triglycerides, that is a risk factor. So my point, Dani, is once you've been evaluated by someone who does preventative medicine, or your internist or your caregiver, they will look at all your parameters and say, you know what? You've got a constellation of parameters here that put you at high risk. You have got to take yourself in hand and become very active and proactive about lowering your risk. That
Bingo, right there. They have to be proactive, and they have to take it into their own hands.
Go back to these things. Let's go through them. I mean, I don't want to leave this program without coming back to what can you do about it. And the big four that you should think about are nutrition and plus or minus supplements that goes with that, exercise and flexibility, sleeping properly and making sure you don't have sleep apnea, and stress management.
Yes, sir. Yes.
Those are, so I think I've said a lot already.
Well, I want to know more about magnesium, and I think people want to hear about magnesium. If you want to hear about magnesium, hit your hearts buttons there. I want to hear about your magnesium, because I am fascinated with magnesium. I have not had a panic attack in probably 15 years. When I was going through my divorce, I had 2 panic attacks. Today, and I think it was a combination of using this new format, seeing if this was going to work. I did not have a panic attack, but I thought, oh my gosh, I got panicky. And so I went to the office and I picked up magnesium packets, like liquid, magnesium packets, and it worked beautifully. I mean, it calmed me down, but that's what magnesium does. One of the things it's a smooth muscle relaxer, right? So it.
Totally. And not only that, there was a psychiatrist who called it the chill pill.
It is the chill pill. And I used it with so many patients. For those of you all who just got,
You just gave an example of how it helped you.
Oh, it did. And so I was calm in about 15 minutes. But guys, this is the book that Dr. Goodman wrote, Magnificent Magnesium. Tell me about this, because I know that you know, as a traditional cardiologist, you can catch some flack for something like this, right?
Well, the reason I wrote the book is because when I discovered how helpful magnesium is, I wanted to educate people, and I wanted to come from a standpoint of saying, I'm in traditional medicine and I understand how important this is.
Yes.
Because we didn't learn about it, unfortunately. You just don't get very many out.
Neither did I. All those degrees you got, you didn't get a lot about magnesium, did you?
We didn't. So basically, I started to, when I heard about it, and I heard about it when I told you at Scripps Integrative, you know, when I worked in the Scripps Integrative health system with Dr. Guarneri, and I started hearing about magnesium, I started using it, and I could not believe it. So let's just go back to some basics. Magnesium's a mineral.
Yes.
And it's really important for the body to have magnesium. And this is the key point, Dani. Our bodies do not make magnesium. Okay. You need to have magnesium, and you need to get it from external sources.
Okay.
So where you're going to find it in your diet, and it turns out predominantly from green leafy vegetables.
What about dark chocolate?
The dark chocolate actually has a little bit of magnesium in it. You can't rely on that. But
I know, I'm just messing with you.
There are things like sunflower seeds.
Yes.
Okay, and pumpkin seeds.
Yes.
Hazelnuts that have a lot of magnesium. So you'll see in my book, I've actually given examples of how much magnesium you get in all these various substances. Yes. Halibut's got magnesium in it. But
I didn't know that.
The key is that you get enough magnesium. And if you don't get enough in your diet, you're going to be deficient. Well, here's the scary thing. I mean, the hard truth is that 80% of people are magnesium deficient.
Yes, they are.
And what is the most important action of magnesium? It's to convert ADP to ATP. It's a cofactor. We need ATP in our bodies. Okay, that's how your body functions, with ATP. Think about your car. If you don't have the right gasoline in the car, it's not going properly. This is the gasoline for your body. You've got to have ATP. There are a lot of cofactors. There's many cofactors. There's NAD, there's CoQ10, there's other factors, but it's absolutely imperative that you have enough magnesium in your body. Turns out that people, when they're magnesium deficient, and you showed my book, right? On the
yes.
It helps with a lot of symptoms because there's so many systems in the body that need magnesium. If you're magnesium deficient, you could be landing up having headaches. You can have palpitations. You can have muscle aches. You can land up having GI problems. You can land up having anxiety and depression.
Yes.
So I found insomnia, for example, that a lot of people, I put them on magnesium and they say, wow, I'm sleeping so much better. Because it's a relaxer, and it works just because there may be somebody listening who says, well, what's going on? It turns out that magnesium regulates calcium and glutamate in the brain. And what calcium and glutamate do is they stimulate the NMDA receptor. So the NMDA receptor is very important for the neurotransmitters in the brain. And if you have magnesium deficiency, then you have too much calcium and glutamate being unopposed, and you get firing of this NMDA receptor, and it starts to create anxiety and depression. So I'm just telling you, you've got to keep that calcium and glutamate under control, and that's what magnesium does, because then you don't get firing of your NMDA receptor overfiring and overstimulation. So that's the mechanism. But I clearly, and I mean this, and I just mean that if you're going to take 1 or 2 supplements,
right,
and people don't realize it, and you can only take 2, and obviously you can take many. The 2 that are absolutely crucial are vitamin D and magnesium.
Yes.
And that's why you like it so much. Because, I mean, you use a lot of magnesium. You mentioned this to me.
I do.
And I'm sure you've seen how people come back and they say, wow, I feel better. I've got more energy. I don't have palpitations. I'm sleeping better. So I have certain cocktails, which is why I call myself an integrative cardiologist. And one of the common things I see is people come in with palpitations, a lot of times associated with anxiety. So they feel their heart fluttering or skipping beats. And as long as there's no underlying structural heart disease, then it's very important. So they need to be screened if it's appropriate. That means it may be a stress test. That means maybe a cardiac echocardiogram. But once I know that these palpitations are benign, I like this cocktail, which I found very helpful. And it's a combination of magnesium.
Okay, guys.
Magnesium, CoQ10, and fish oil or krill oil. And I found this cocktail so helpful. I get people come back 4 to 6 weeks. They say, wow, my palpitations have gone.
Okay, so they're going to want to know, what form of magnesium do you like? And I know what you're going to say. How much magnesium, how much CoQ10, and how much fish oil? Because they've been commenting up here. What's the recommended dose?
So the first thing you should know is there are many types of magnesium.
Yes.
I don't push one magnesium. I happen to have one brand that I do like, and it's called Jigsaw. Yeah, and it's got a slow release technology, and that's the only reason I like it, because it's less likely to cause GI side effects, and it's very well absorbed. But you can get any magnesium that ends in ATE.
That's what I use. I use OptiMag 125, which is glycinate chelate.
Is that pure encapsulations or design?
No, this one's Zymogen.
Zymogen, okay.
This one's Zymogen. And I also use Metagenics Mag 3 and 8.
Absolutely.
So I only use ones that end in 8 as well.
Because those are the ones that, so there's some people who say that 3 and 8 is better if you're talking about getting across the blood-brain barrier, because they did one study and nobody else has really done the study. I suspect they all get across the blood-brain barrier, but if there is a question about it and you want to take one that's been proven, then 3 and 8.
Yeah.
The way to go. And it turns out that Designs for Health has one. I think it's Neuromag, and basically they use the 3 and 8. I use the Zymogen one. And the Metagenics one. They do one in Designs for Health as well. So how much magnesium do you? 3 milligrams per pound.
3 milligrams per pound. Okay.
Anyway, 100 pounds, you're going to get 300 milligrams. So most women that I take care of are taking about 400 milligrams.
Okay, so about 400.
About 500.
3 milligrams per pound. Okay, that's good. That's I haven't done it that way before. Okay, CoQ10. How much CoQ10?
So CoQ10, minimum of 100, but I like to use 200. 200 milligrams of CoQ10.
Okay.
So it turns out that, there's this question I'm sure you get asked, should I take Ubiquinol or should I just take
Yes.
So most people can take CoQ10. It's just fine.
Okay.
But I do this scientifically. If they do not absorb the CoQ10 well, and some people don't, I use Ubiquinol because it's better absorption, but it's more expensive.
Okay, so I just got in from the show. I bought Designs for Health CoQ10, but I don't know.
Because if it does, Ubiquinol is just another. It's the form of CoQ10 that gets metabolized in the body to Ubiquinol. So you just you're bypassing a step.
Okay.
So there is no option, and you want to make sure you're getting the best way to get CoQ10. You can get Ubiquinol, but most people have no problem with CoQ10. So I use CoQ10 200 milligrams a day.
Okay. Magnesium 3 milligrams per pound, and then what about how much fish oil do you like?
The magnesium you can split up. By the way, you can take half of it in the morning, half at night. That's one way. If you feel like it, you want to see if it's helping you sleep. Sometimes I tell people take the whole lot of time.
I take all of mine at night.
Okay. Yeah. So then the next thing is so this is now we're talking about omega-3s.
Yes.
And you can take 1 gram of krill oil.
Okay. 1 gram.
Or you can take, because krill oil actually is better absorbed. You don't need as much as when you take a fish oil. And it contains astaxanthin, and it contains phospholipids, which help with absorption. And as you know, I wrote a book about that too.
Oh, yeah.
You mentioned. But otherwise, you take 3 grams of fish oil. And you want to take one of the fish oils of one of the big companies that you've already mentioned.
You bet.
You want to use somebody that you know is mercury-free. So there are certain brands out there, you know better than me, you can tell your audience. The natural world of where they, some of the companies that are very careful to make sure that they process the fish oil very well to remove any chance of having mercury.
I use Metagenics in the office. This is my favorite one. I just got one in from Designs for Health this week, but I tell patients, if you don't want to use Metagenics brand, I use Nordic Naturals or Carlson Labs. I think these 3 brands are fantastic. Designs for Health has a brand new, I don't know if you tasted this or not, but it is excellent at the show. And I just got it in. It's a liquid and it is phenomenal. We tasted it at the Hashimoto's meeting Friday night. Excellent. But you like 3 grams. Okay. So 1 gram of krill or 3 of EPA DHA.
You could say, well, try 2 grams. I just want to give them a good dose.
This one's 2.5.
That's fine.
Okay. That'd be okay. Okay. All right. So that's your cocktail. 2
and 3 grams. So that's my cocktail.
But we have a patient or someone who's just asked on here, how do you know if you don't absorb CoQ10? How would you know that?
Good question. You get a blood test, and it's through LabCorp, and you can get a CoQ10 level. You want to see your CoQ10 level above 2.2.
What?
So you would know that you're not being absorbed because your level doesn't go up.
I didn't know that. Now, I wonder if Quest does that. I'll find out. I don't know.
About Quest, I know we send it to Lab. I send it to
Lab. Okay. All right, guys. So if we can do that in the office, I'll find out.
And that's enough. And also, you could say to an integrative person who's doing these tests, could I see what my CoQ10 levels are? Because that's where you could find out whether you even need to take it. I happen to like CoQ10. It's a very, very, very good cofactor and antioxidants. And so I believe that it should be part of the mainstay of basic supplements.
Okay. All right. Yeah. Well, I'll add that to mine. I think you need a good multivitamin, the best fish oil, the best D3, the best K2, and a probiotic. And then there's magnesium and CoQ10. So it's like, I
know. So that's why, Dani,
there's 6 things.
So that's why I try to combine them. I try to take the D3 with K2.
Yes.
You put it together, and there are companies that'll give you the combination. Then you've simplified it.
Yes, you're correct.
You mentioned, as I said, so you take a fish oil or krill oil. You don't, you take one or the other.
Do we, Kelly's asking on there, do you know a good krill oil? Because I don't use krill oil at the office, and so I don't have a recommendation.
I like the krill oils where Neptune is one of the manufacturers of the krill oil, because I know that and of course there's, there are other krill oils out there, but the one I use is NOW now. And because the people that make that krill oil are from a company called Neptune, and they make very pure, excellent krill oil. But of course,
I like now products.
Krill oil called Mega Red. That's another one that you could take. I happen to prefer the as I said to you, the Neptune. But that's also fine. You can take a krill oil. You just want to make sure it's from one of the reputable manufacturers, and I've given you 2 of them.
Okay.
So there's a krill. The brand is called Now, NOW.
Yeah, I use quite a few of their things in the office, and their prices are good.
Yeah, exactly.
Patients can afford it.
I like for some patients. Just let me give you some advantages of krill. You can take less, because I told you that you've got better absorption because it contains phospholipids. It's got astaxanthin in it, which is an antioxidant. So if you've got any problem with a fish oil where you find yourself belching and smelling or tasting like fish, or you have, which is one of the problems for some people.
Yes, I know.
It doesn't do that. Because it doesn't get rancid in your stomach. Now, there are other fish oils out there that are doing a good job. Some of them actually add astaxanthin into their formulations. You want to ask when you get a fish oil, has this fish oil, do we have something else in it to prevent it getting rancid in your stomach, or is it well absorbed? There are, as you've mentioned, you've already given the names of a few companies that have excellent fish oils.
Okay. Okay, so how much vitamin D? Lisa's asking, how much vitamin D do you, but I think, Lisa, that depends on your level. I do not give vitamin D just willy-nilly. I always want to know what their level is, right? And so 30 to 100 is the range for us. But I mean, I think optimal is going to be 50, 60, 70, somewhere right around there. How do you feel about that?
So I agree with you. I check the vitamin D levels, and just remember, you've got to check vitamin D, and you want the hydroxy form. So it's not 125, it's the 025. Just remember, when you're checking it, you want the hydroxy vitamin D. That's what you check, okay?
Mm-hmm. That's what we check.
And if you are less than 30, you are deficient, okay?
You bet.
That would be the basic minimum. I keep the range I like is between 45 and 55. I know there's some people like higher than that, and you can make a claim. But it turns out that I saw a study where they looked at an African tribe, and these people had longevity, and their vitamin D levels were 50 on average. So
really? I always try to get it higher. So, okay.
Well, I mean, you got to be careful as well.
Dan. Well, I don't want it up past 80, 90.
I found a patient once who came to see me. She said, I don't feel good and I'm nauseous. Nobody could figure out what was going on, and her vitamin D level was way over 100.
Oh, yeah. No. I don't.
We'll let you check it. When you go on vitamin D3, which is what you want to take, that after a few months, 2 to 3 months, you check again and make sure that the levels are in a good range.
Yep, I check it in 3 months.
So the answer to Lisa's question is get your level checked.
Yes, always get it.
That's the same with magnesium. We can actually check a magnesium level. It's called a red blood cell magnesium, not the magnesium.
I want you to share with them what you said. I learned something from you in that. Well, I learned a lot in New York, but from you. But sometimes my patients' magnesium RBCs do not raise the way I thought they would. I've got them on a fabulous magnesium, multiple different kinds, whatever, and it doesn't raise. And you said, don't stress about that. You mentioned this. I can't remember when, but don't stress about that because it's only like 50% accurate or something. Is that correct?
That's what I said. So I use it, and it tends to be like something I'll use to say, yes, your levels are low. And then I do repeat it. But if they don't go up, I go, you know what? Not everybody's going to go up. We don't have the technology today to get really accurate ways of knowing what your tissue magnesium levels are. So I get excited about that. If someone's taking the dose I gave you and they're feeling better, I tell them don't worry about the level not going up. Okay.
All right. And I have used that all last week, actually, because I had several patients whose levels didn't go up, and they say they're doing great. Exactly. Okay.
Sometimes I get a person who says, I'm still having problems and I may up the dose, especially if the level's still low, because I do have some people on 800 milligrams, someone who's got terrible, maybe they got terrible headaches, or maybe they're still having muscle aches. And I check it just to make sure that their RBC magnesium is not getting really into a high level above 6.5. So I am a big believer that we try to get magnesium levels, if we can, above 5.5. Above 5.5. Okay. So if you're below that, I think it's suboptimal. But let's have the caveat of understanding, because it's not 100%, it's only sort of 50% accurate. We can't really get too excited because it may be an inaccurate situation. But I can tell you, most of my patients are suboptimal. Do you check RBC magnesium?
Oh, absolutely. And yes, I do.
What are you finding?
Oh, nobody's where they need to be. And it's like D3, So no, and the moment I get them on magnesium, it's fascinating. The majority of them, they come back in at their follow-up and they're like, oh my gosh, Dani, I'm doing so much better. I'm sleeping better. My anxiety's less. My heart palpitations are less. I'm pooping better. Everything is better. I mean, for the most part, with a really good magnesium. So yeah, I use a lot of magnesium.
One thing we just have to tell people, magnesium is really safe, except in people who have kidney problems.
You bet.
You cannot just take magnesium without speaking to your doctor and knowing about your kidney function, because it's dangerous for people who have kidney disease.
Yes, it is. How much K2 do you like? Now, I use megaquinone, but Lisa was asking, how much K2 does he like? And you wrote a whole book on K2. I can't wait to read this.
I know you put it here, so I don't know if through this. But
oh yes, there it is. Guys, if you, I would get this, I want this book. I need to get this book because I have been, my patients know, I have been all over K2 the last probably 9-10 months. And actually I had beef liver tonight for dinner. My whole house here smells like liver and onions. So K2 is found in organ meats. Is that correct?
Yes.
And not many people eat liver. I hadn't cooked liver in years. And
in certain dairy products, you can't get enough, K2 from your diet because it's the same stuff that we try not to eat a lot of. It's fermented cheeses, like powdered cheese, and it's beef liver. You can't eat that much of that. And dairy,
I love it. I got a whole plate of it over there. I'm going to eat it at the office tomorrow for lunch.
The people who get plenty of vitamin K2, they live in Japan and Asia because it's fermented soy. It's called natto. And
that stuff's disgusting.
Right.
Really?
Remember in my talk, I showed that picture.
That's right, you did.
But so you can go to a store that sells Japanese products and get some natto, and you take a teaspoon every day, you're getting enough. You're getting plenty of vitamin K2. But most people can't tolerate it. It's like slimy. It's like seaweed.
I don't want any part of that. How much K2 do you like for your patients?
I'm going to give you the range of minimum and where it's sufficient, and it's 180 to 360 micrograms per day.
Okay, so I thought you were going to say 180. Okay, so this one that I use is 320.
That's fine. So I tell my patients, most of them 180. But I recently at this conference landed up speaking to a guy that's an absolute expert, and he's saying, 360. To be honest with you, put my patients on 180 because the studies that had 180 were the ones that I saw benefit the results were with 180. But
this is for 2 capsules, so I could just give them 1.
Yeah. So what I'm saying is, you know what? If you're getting 180, you're getting enough. But if you want to take 360, maybe it's a little bit better. We haven't proven it.
Okay. So we've got Melissa asked, is magnesium okay if you have kidney stones?
Kidney stones is okay, because it's not there's no magnesium kidney stones. It's if you check your kidney function and your BUN and creatinine are elevated. So you're going to have a deterioration of renal function. So sometimes people have kidney stones that does cause a problem for kidney function, because you can actually get a problem, and it's usually an acute problem. You get a kidney stone, and if it's blocking up your ureter, that backs up and it causes a problem. You can actually get high creatinines if your ureters are blocked. But for the most part, that's not an issue. This is about kidney function. It's not about kidney stones.
Okay, perfect. Okay, what else do you have to say? Because I know it's already been almost an hour, and I know I've taken you away from the Oscars.
Maybe you'll have me back, but I'm going to have to go in a few minutes. So
I know you are. Anything else? Any final thoughts to say?
You know what? Firstly, as I told you, it's a pleasure to come on. I think we spoke about a lot of stuff. There are a lot of other supplements to talk about, and which one should you take, and should you take a probiotic, and what about the microbiome? But I think the key for tonight is we spoke about cardiovascular disease.
Yes.
And I want to make an appeal that people don't just go, oh, I feel fine, so I must be fine. What I say is go and be checked and understand that if you've got a family history, you already have increased risk. So make sure you know about all the other things, your blood pressure, what an ideal body weight is, that you go and find out what your cholesterol is, that you're not smoking, that you are making sure that you're not pre-diabetic or you're not diabetic. And if you are, then you want to be take care of yourself. So we know for sure, and I want to leave you with this point, 80% of heart attacks and strokes are preventable. And I think that's where we're going to leave it, because if we can prevent 4 out of 5 strokes, you can take all your statistics and you can get 20% of those statistics instead of what you mentioned, which would make a huge difference.
Wow. Isn't that fascinating? Thank you so much. Do you have your D3 book there beside you? Because I don't have it here. It's at the office.
My K2 book, and then I've got the Krill book, which looks like this.
Oh, that's what I mean. The Krill book. I meant the Krill book, not the D3. And the Thrill of Krill, which is a fabulous name.
If you go on Amazon, all my 3 books I saw the other day, they're actually saying you can buy all 3 books, and it's really, I'm quite amazed. They're almost giving them away.
Well, I'm going to
tell your people know I hardly make a cent from these books. The thing for me is just that I educate people. So,
well, you're doing a fabulous job. This book is so well written. I told you today, I love it. I mean, anybody can understand it, even a girl from Gilbertsville, Kentucky, with an 8th grade education.
I wrote the book specifically so people, laymen, could understand it. This is not, and I've actually had medical students read it and they loved it. Because, as you know, the first part of the book is explaining cardiovascular disease.
You bet. It's fantastic the way you did that. I wish that when I was in school at Vanderbilt, they would have explained it like this, because I can't stand EKGs and all that. It looks like everybody's having a heart attack to me. Nobody explained it well to us. So anyway, I appreciate you so much, and thank you for so much. And guys, if you all, Dr. Goodman's website is DennisGoodmanMD.com, correct?
That's it.
It's a fantastic website. Check it out. And I thank you so much. And I am so grateful that this worked tonight. And thank you guys for giving us your time. And Dr. Goodman, I will talk to you later. Thank you so much. And if you all have any questions at all, post them up here, and then he'll be able to see those later if we need to answer.
Yeah, and if someone has a question, Dani, get it to me. And I'm very happy to get you the answers, and keep up the good work.
All right. Well, I appreciate it. Thank you so much. You are our very first long distance guest.
Now you know that you can get guests on.
Well, I'm going to tell you what, we started at the top. You set the bar high. It's going to be hard. I'm going to have to get Deepak Chopra or, somebody like that on.
And next
time,
you don't read the bio because it takes too long. It just goes right in.
That was really long. I know. All right, guys. Have a good night, and thank you so much, Dr. Goodman.
Bye.
Bye-bye. All right, guys. So he's gone, and I'm still on here, and I appreciate you all. We had so many people on here tonight. So I'm going to sign off because I know that we've gone over. And next week, Dr. Motley and I will be back here live on Sunday night service. I have so much to tell you all. The yoni steaming is it's this close to being ready. I did the first steam yesterday with Dr. Leslie Shue for her YouTube channel. And we did a live video. We did a video of us steaming, and it was absolutely hilarious, and it was wonderful. I loved it. If you're interested in that, Steph, STEF at DaniWilliamson.com. You can email her and get on the wait list, or get on the list. There's not a wait list, the list for that. But guys, I appreciate you so much, and what a great treat to get him on here tonight. Check his website out, DennisGoodmanMD.com. All right, you all have a great night, and I'm sorry I kept you. I hope you DVR'd the Oscars. I didn't get a chance to. So, all right. Have a wonderful week. Eat well, move well, sleep well, poop well, decrease your stress, and have community, and laugh. Those are 6 things that are going to help you cardiovascular wise and just in general. So have a good night. I love you guys.